Hi, I'm Joanne Conroy, and I am pleased to be joined via Zoom today by Rick Pollack. Rick is CEO and President of the American Hospital Association. I have just begun my term as board chair of the AHA, and this is an excellent opportunity to discuss the association's goal for this new year. Welcome, Rick.
Thank you, Joanne. And we are so fortunate to have you at the helm of the AHA this year. You are nationally recognized and widely respected and universally admired for your innovative approaches to healthcare delivery and your leadership at Dartmouth, a renowned academic medical center that serves so many rural communities. I know it combines your passions for not only serving rural communities, but also training the next generation of caregivers. So you're unquestionably one of the most influential people in healthcare, and we're honored to have you in this leadership position.
Well, thank you, Rick. You're talking to two things that are really passions of mine is rural healthcare and actually training the next generation of leaders. So our readers and listeners love to get to know people that I interview. So before we launch into, what's going on in healthcare and how the association is putting their arms around that, let's hear a little bit about your background. I know you grew up in Brooklyn and are now based in DC, which makes sense since you have worked in policy and politics for many years. But I think our audience would like to know about your path from Brooklyn to DC, both personally and professionally, because it's made you an incredibly effective influencer in DC.
Sure, sure. Well, I got to say, I'm a first generation American. All my parents, grandparents, aunts, and uncles were born in Russia. They escaped a religious persecution and came to America in the 1920s after the Russian Revolution. Where they came from is now what's now Belarus. I'm a product of the New York City public school system, which was quite good in its heyday, if you will. And I'm also a product of the State University of New York. The State University of New York, I was a political science and communications major. They don't have a flagship facility. They have a lot of four university centers, eight four-year arts and science colleges, and they also have this thing called a Washington semester program. And I was selected from the Cortland campus to represent them in the Washington semester program that offered me an internship opportunity. I ended up interning for Congressman Dave Obey of Wisconsin, and then he hired me as a legislative assistant after doing that internship. I went to graduate school for a master's in public administration at night and worked for him. And I never did health issues. I did education and labor issues, actually, on the Appropriations Committee, which is a subculture of the Congress in and of itself. I actually met my wife in his office, who was also a Capitol Hill staffer. We only overlapped for 2 weeks, but I guess that was enough. And for a congressman that had a 40-year career or so and became chairman of the House Appropriations Committee, we were a part of that family for many years and continued to be a part of that congressional family. I left Capitol Hill and I became a lobbyist, as many people do, and we can talk about what that really means. And I worked for the American Nurses Association for a couple of years, and they didn't want someone that knew healthcare, oddly enough. They wanted someone that knew the process of essentially getting funds for nurse training programs and nurse research, which we were getting off the ground at that time. And then I made the pivot to the American Hospital Association, started as a lobbyist, then became vice president for legislation for about 24 years, was executive vice president for our Washington operation, and was honored to become CEO about 8 years ago.
You know, your path is really interesting because there's something about knowing how things get done in Washington that you almost have to be part of it to really understand it. That's why they probably call it inside and outside the Beltway, because within that circle of highway around DC, you know what? There is a high concentration of individuals that work in legislative offices. They are civil servants. They work on the Hill. When did you know, though, that you really wanted to immerse yourself in the industry of actually creating legislation and regulations that will improve care, educate individuals, and keep our country safe?
It was really, when I was in high school, it was the Watergate era and the Watergate hearings and seeing the Congress in action. And actually, I thought I would really go into journalism back then and communications. But then I decided I wanted to be more involved as opposed to being a reporter of events or a observer of events. And that essentially took me to political science, which took me down this route. And you're right. There's a lot about the institution on the legislative side in particular that one has to understand. And frankly, at the American Hospital Association, almost 90% of our frontline lobbyists either have experience on the Hill or at the state level. And in this day and age, it may sound a little bit sort of odd or to sort of say, you have to have respect for the institution and understand how it operates to your report, to your point.
Yeah. Even though I think we see a lot on social media, it's not been the first time that our elected uh, houses and the Senate have been in turmoil. And they generally work their way through it because they appreciate what they've been, placed in those positions for, which is actually to serve the people that elected them in a way to make sure that the country runs effectively and efficiently. Um, there's something about the activity on the Hill, though, that reminds me a little bit about kind of a trading floor when there's some big swings in the stock market. There's this level of tension and intensity that I don't think people appreciate. I mean, there are staffers that, they will stay there 24, 36 hours because there's still work to be done and they don't go home. Um, how would you describe it to kind of the average kind of viewer that may say, why, what is it like actually living and breathing politics in DC?
Well, it's changed a lot over the years that I've been involved. Of course, today, everybody knows the situation is much more polarized in terms of the politics, and that gets very dicey, and it's not nearly as collegial as it used to be. And it all ranges from districts that are gerrymandered in a way in which the people that are elected only play to their base. And if you're a Democrat, you're playing to a liberal base. If you're a Republican, you're playing to a conservative base. And the moderate middle has vanished over the years. There aren't many. In New England, we used to have a lot of moderate Republicans. Other than perhaps Susan Collins, you don't have that. You used to have John Chafee and a lot of others that sort of fell into that category over the years. I just don't have that anymore. So things are a lot more difficult and a lot more polarized. And the other thing that goes to what you were mentioning before is Congress often behaves, they always have, but even more so now, and you're seeing it play right out live right now. They behave like college students. That is, they don't do things until there's a forcing event or a deadline. And right now, this Friday, the federal government runs out of money again. And that's why people are scrambling to put together a deal to get over that hump. And that's where that whole issue of, a lot of folks working around the clock and on weekends because there's a fiscal cliff coming and there are a lot of issues that are attached to it. And the other thing is that now actions generally get wound up in big packages. And the big packages become the vehicle for a lot of policy being dealt with. And that again leads to the kind of environment where it gets to be such high stakes because everything's wrapped up in one big bill.
Yeah. Let's pivot and talk a little bit about the American Hospital Association. And you
Right.
talk about kind of respect for the institution. Why pivot to the AHA? And what is it about the institution of the American Hospital Association that's so special?
Well, when I became a lobbyist and I was working at the American Nurses Association, obviously nurses are very special. They are the backbone of the healthcare system in so many ways. But what attracted me to working for hospitals is that hospitals are so different from any other sector of healthcare. We are essential to the well-being of every single American. We provide life-saving services 24/7, 365 days a year. We fund, we test, we do clinical trials to find best practices for patient care and for outcomes. And, we are in the forefront of providing all sorts of specialty care, often on the edge of scientific development. And to be able to represent organizations that do that was a very special opportunity to me that attracted me to AHA. Now, in terms of AHA, what is AHA? We are the umbrella group. There are 12 other national hospital associations that represent different sectors, whether it's teaching, whether it's faith-based, whether it's academic medical, whether it's for-profit. And we work very closely with those 12 organizations. There are, of course, 50 state hospital associations, and we work very closely with them. We're on calls with them weekly. We have all of them in a meeting here in Washington tomorrow to make sure we're all lined up for this coming year. We're 125 years old. And interestingly enough, when people came together initially 125 years ago, they came together to talk about learning about the financing of healthcare, the management of hospitals, and how to improve the delivery of services. And we're still at that in terms of what we're doing. I see the association really having 4 functional areas, one of which is learning, bringing our colleagues together to learn from each other. And as a national association, we're able to take people out of their competitive markets, if you will, where they're more willing to share best practices and strategies. Another second function of the AHA is advocacy and representation. And that's, often referred to as our core competency. And I say advocacy in a broad sense. It's not just what goes on in the Hill that we talked about before. It's what goes on in the regulatory agencies. It's what goes on in the courts. It's how we interact with the media and the think tanks and other academic institutions. The third thing, in addition to learning and in addition to advocacy and representation, is thought leadership. And that means bringing new ideas to the table, or if we don't like something that's happening, offering an alternative to what's being suggested. And the fourth thing is being an agent for change. And that often involves moving the field in a direction that they need to move in and helping them get there. And whether it's quality improvement, whether it's health equity, whether it's things like cybersecurity. We don't want to boil the ocean. We want to focus on the significant priority items where we have some expertise to offer. So that's the way I look at the association.
Now, I'm sure that my employees will say, well, as chair of the AHA board, what do you do? And how can you actually best serve that organization? How would you answer them?
Well, first of all, I would say that you've already been doing a little bit of it because you've been on our board of trustees for a while. You've been serving on the executive committee. And when you're in the chair, it's really, in many ways, a 3-year commitment. I mean, you were chair-elect, and now you're chair, and then you'll be the immediate past chair. So you're at that leadership table for a period of time. And, when you say, what's the role of the board chair and what's the role of the board? Well, the role of the board chair, and I know you appreciate this, is to make the CEO a success, right? And, and I've always been blessed with having chairs that kind of view that, and I'm sure you view it the same way. But, beyond that, it's really to guide the strategic direction of the association, particularly around the strategic plan and our advocacy agenda. It's, helping us secure consensus on key decision points on high priority issues, those that we can anticipate, and frankly, things that we can't anticipate that just pop up. And, every year there's issues that kind of just pop up, that we couldn't anticipate. And I suspect we will, as a partner, work through those as we go through the year. And then, of course, as board chair, there are the fiduciary responsibilities of any organization, as it relates to overseeing the finances, compliance issues, governance, and ensuring future leadership on the board. The last thing that's also really important, and we look to our board chair is to be a key spokesman on behalf of the association, where as a physician in particular, you bring particularly valuable insights and perspectives. And I know that you and your colleagues in the past, we always look for you to ask us the good, hard questions. And we also ask for you to give us ideas that we might not have thought about. And you've been doing that all along, and I know that you'll continue to do it in a big way over the next year.
Well, thanks, Rick. I certainly hope to do a good job with you and for you. But I acknowledge that I've got some really big shoes to fill. I mean, John Halpert and all of his predecessors that actually helped steer the organization through COVID. It's been close to 4 years. And talking about things popping up, I'm not sure that any of us anticipated the impact that COVID would have on our organizations for as long as it has affected our industry. And there are a number of things that are changed that are not going to go back to the way they were pre-pandemic. In some ways, that creates challenges for us. In other ways, it creates opportunities. I know that staffing, and we talk about that a lot, is a huge issue. Some hospitals and health systems are having a hard time financially staying afloat. Our supply chain is a challenge. And there are probably going to be more challenges as unrest around the world actually expands. And that's just a small sample of the issues that we're facing. I know the AHA has a number of task forces, as you indicated before. When we can bring best practices together to advise the entire industry, it's incredibly helpful. The task force on workforce and on violence and hospital violence, and how do we actually manage that so we keep our patients and the people that work with and for us safe. Given everything that's going on, when you think about the priorities for 2024, what are the top of mind issues for you?
Well, speaking of John Halpert, your predecessor, I know that you did a interview with him, a chair's file, as we call it. And I thought you really said something in that interview that's really important, and you articulated it really well, and you kind of just touched on it. And that is, you called it the fractures in the healthcare system, whether it's the financing, the workforce, the access issues, the behavioral health, the supply chain. And, one of our big priorities is to make sure people understand, the policymakers, the media, and others, that there are, in fact, those fractures that are there. But the other part of that story is the healing of any fracture that needs to be done, and the rehab or the restoration. And, that's kind of what we're focused on. So when you talk about the healing and what the priorities are, I'll put it in kind of two buckets, okay? The most immediate bucket is what we're dealing with between now and literally Friday of this week. Because as I said before, things happen in one big bill. And the government funding bill, where half the government runs out of money if they don't do something, and they will inevitably kick the can down the road. And when they kick the can down the road, whether it's this Friday or not, they will attach a health bill to this big funding package, because they know that you got to keep the government open. Nobody wins by shutting the government down politically. And there are some big issues that are in play right now. We want to make sure that Medicaid dish cuts that are scheduled to kick in, that, by the way, we've kept on ice for literally 12 years since the ACA was put in. That's an $8 billion item. We got to make sure that that moratorium sticks for at least another year or two. So that's right in front of us right now, and that's part of making sure that that the financing fracture doesn't get any worse. Another big issue is what is referred to as so-called site neutrality. Hospital outpatient departments are paid higher than other settings. It's a payment differential. People question whether we ought to get that differential. They think that any service, regardless of where it's provided, ought to be paid the same amount. MedPAC suggested $134 billion in reductions by neutralizing those payments, taking away the differential. Right now, Congress is looking at a proposal that actually passed the House that would employ site neutral for a limited amount of services, and it would save $8 billion. We're trying to prevent that from happening, and that's an $8 billion item. Again, financing fracture, if you will. There are a whole host of other things that are in a package that either will be looked at this Friday or mid-March around pricing transparency, around reauthorizing something called PEPFAR, which is the Global AIDS HIV program that has expired on September 30th. PAPA, the Pandemic and All Hazards Preparedness Act, that's a part of this package. That expired on September 30th. We have a problem with physician payment. Physicians got cut under the payment system beginning this calendar year. That is something that's on our list that needs to be corrected in this package. Telehealth. There are a lot, you talk about COVID, there are a lot of flexibilities that were achieved in COVID around telehealth. Those expire at the end of the year. We'd like to get those extended. There are a variety of things that are all pent up. So that's the immediate. Now, getting past the immediate in terms of priorities, certainly coverage is a very big priority for us. And we're watching real carefully the Medicaid redetermination process, working to make sure that that's implemented in a appropriate manner, making sure that those that get disqualified from Medicaid can get enrolled in the healthcare marketplace. And we want to make sure that the enhanced subsidies for those that are of low income in the marketplace to make healthcare affordability, that those enhanced subsidies that were part of the COVID relief package, that those get extended when they expire. You mentioned the workforce. There's a whole host of workforce priorities that we have, whether it's our own efforts in the field of caring for the caregiver, whether it's retention strategies that we share, whether it's building the pipeline through federal support for training programs, whether it's working with you and your colleagues in developing new care models, and whether it's violence prevention, where we want to make assaulting a healthcare worker a federal felony crime. That's a big priority. I'll take off just a couple of others. Holding commercial insurance companies, those corporate insurance companies, responsible for their behavior is very important. We see payment delays, we see payment denials, we see prior authorization obstacles being put in front of our caregivers where they're taken away from the bedside to deal with asking for permission on the phone from insurers that are focused on denying care, as opposed to us that are trying to provide care. And it exacerbates the workforce shortage because it takes people away from the bedside. We've had a whole host of initiatives to hold those insurance companies accountable for that behavior, to make prior authorization a more streamlined and less burdensome approach. That's also a priority for us. Advancing patient safety is another big priority, and we have a whole program in that regard. And cybersecurity, of course, is another issue that's very important. And we want to make sure that everyone is doing things to not only button down on their side, but we're working with the FBI in a partnership because, so many of the intrusions are coming from state actors and they really have a significant role. So those are among the priorities that we consider to be top of the list.
It's a busy year and your team and you are so effective in actually blocking and tackling things that are going to undermine the sustainability of the healthcare system. But when people say, what has the AHA done for our communities? I can honestly say that your team was laser focused on the provider relief funds during COVID when we shut down 75% of our business. That really enabled us to keep our employees working, to continue to deliver services when there's a question about whether or not we were going to have enough revenue to keep the trucks rolling and the lights on and the heat on. And I think a lot of Americans don't actually appreciate how much work the American Hospital Association did to get that money to hospitals and to providers so they could continue to deliver care. So thank you. Now we
Sure.
have,
Yeah, and I can just add something.
yeah,
The funding was really important, but the regulatory flexibilities that we were able to achieve were also very important. And some of those sparked innovation. And when you talk about telehealth or hospital at home, those were all regulatory flexibilities that really came out of COVID relief, and things that expire that we want to get extended.
yeah. Now we have some quick questions from our
Sure.
staff. One of our emergency room supervisors is asking a question about how are we focusing on delivering care closer to home, more accessible, especially in rural communities? I mean, they're pretty lucky. We have a world-class academic medical center here in probably the most rural area of New England. But there are many people living in rural communities that don't have access to care, like at Dartmouth Hitchcock. How is the American Hospital Association looking at actually strengthening the rural healthcare network?
It's interesting. Half the rural hospitals in the country are now connected to systems. And that is an effective way of being able to ensure access to a wider array of services and to ensure care coordination. And that, I mean, you're an example of doing that. And so, half of our folks have that kind of an arrangement. But to the heart of the question about providing care closer to home, it's those two issues I just mentioned a second ago that came out of COVID relief. It's hospitals at home, and telehealth. That really goes right to it. And in both cases, those waivers for those programs will be expiring probably I think it's at the end of this year. And those will need to be extended, and those are definitely on our to-do list of expirations, and that gets you to providing care that's closest to where it's needed. And of course, when it comes to hospital at home in rural areas is a little bit more challenging, but telehealth is really gets to providing that kind of access.
They just had the Iowa caucus, and we have our Republican primaries or Republican debates next week. Um, how do you navigate this incredibly partisan environment and get people from both parties to really focus on healthcare, which should be a shared interest and something that they could do together? Um, how do you approach that, Rick? Because it seems almost impossible to navigate that.
Well, in this election season, if you will, it's interesting that healthcare at the presidential level, now that you mention Iowa and New Hampshire, really has not gotten too much attention. And that's unusual because, for the last several presidential cycles, it got a lot of attention. Going back to President Clinton's election, where healthcare was front and center. It didn't really happen in a significant way during that administration, except for child health care expansions in the CHIP program. It really wasn't front and center during the Gore Bush race, but it was still out there and is still being talked about. And certainly with President Obama, it was a big issue. And President Trump wanted to do repeal and replace. But you look at the debate thus far, and you don't hear very much about healthcare. And it is interesting because it's different. And part of it is because, it usually is considered more of a Democratic friendly issue than a Republican friendly issue. Now, I got to say, AHA is bipartisan. We don't take sides in the presidential elections. We are active in the congressional elections, and we act in a bipartisan way when it comes to navigating our legislative agendas. But it is interesting that when you look at the discussion on the Democratic side, clearly the issue of women's reproductive services is going to be front and center for the Democrats. Prescription drug pricing and the cost of prescription drugs is probably something that they have in common that will be front and center. And then, some Republicans may take up former President Trump's repeal and replace, even though that I think is very unrealistic. And certainly you'll see President Biden focus on building off of the ACA. But beyond those issues, it's not as if there is a big discussion on healthcare issues. Um, Affordability will always be part of the discussion, but it really hasn't been front and center beyond what I just mentioned. How do we navigate all of this? Well, very carefully. But I think whatever you see us take on an issue, we always try to make it bipartisan. Take for instance our effort to make it a federal felony crime to assault a healthcare worker. That's sponsored in the Senate by a Democrat and Republican, Joe Manchin and Marco Rubio. It's sponsored in the House by a Democrat and Republican, Madeline Dean of Pennsylvania and Larry Bouchon, a physician from Indiana. And almost everything we do, we try to do it in a bipartisan way and stay under that political crossfire, if you will.
Yeah. So last question from one of our employees. If you had a magic wand and could wave it and change one thing in healthcare, what would that be?
For me, it would be having coverage for all. And for every American to have coverage and not fear, a financial consequence for seeking either preventative care or care for illness or injury. That would be my magic wand. And I say that in the context of having been at this for some years. And, everybody used to, when the ACA was going through, people referred to it as universal care. And we supported the Affordable Care Act. We defended it in the courts. We defended it in the Congress. We still think it's a platform that's worth building upon. But that didn't get to universal coverage. On its best day, 23 million people would be, are still excluded from coverage. So we still have a ways to go to truly get to universal access. And that's certainly something that I would wave a magic wand and want to see happen. Now, I have to caveat that and say there's a difference between coverage and access, right? It's great to have that insurance card, if you will, but if you don't have the providers, us there to provide the access in both urban and rural areas, then we haven't achieved the ultimate goal. So I say coverage and access for all.
Yeah. Well, that's great. Well, thank you, Rick. It's really been wonderful for you to dedicate this time to me as I begin my new role, as well as our viewers.
And thank you for inviting me, and thank everyone for what they do day in and day out to care for our patients and communities. One of the special things about hospitals, we're always there, ready to care, and it's an honor and privilege to say that we represent you.
Thank you so much, Rick. To everyone watching, we thank you for joining us and see you next time.